So the phone rings and you've got a P1 tasking to Mudgee. And so maybe if you're from HEMS, this is a primary turn secondary, or if you're from NETS, this is a retrieval out of Mudgee Hospital. But try and imagine it the way it fits into your practice. So the information so far is pretty limited. You hear that you've got an 8-year-old girl and she's fallen from a horse and she's been trampled, unfortunately. The accident site is only 20 minutes from the hospital, so the local crews are heading out there with a plan to bring her back into town, into Mudgee Hospital, and you're going to rendezvous there. So you get in your helicopter, and on the way out, you get a little bit more information. You've got an 8-year-old female. She weighs 26 kilograms. Her airway is patent. She's a little bit tachypneic, but she's got good sats on oxygen. She's showing overt signs of shock. She's tachycardic at 140. Her blood pressure is 65, and she looks pale and unwell. Now, she's got a good GCS, though, but she's got a lot of pain and a lot of abdominal pain and some bruising over the left side of her abdomen. So you arrive in the hospital, and the patient's still about the same, similar obs to this. New information is that the ED doctor, as a CMO working in Mudgee, has given 1 unit of O negative blood, and her heart rate still remains at 140. She's got a lactate of 5, and you repeat your examination, and it's as described in this mystery. You perform an E-fast on the patient, or if that's not in your skill set, the ED doctor there performs an E-fast on the patient. And what do you see? There's blood in the belly. She's got fluid in her abdomen. And so at this point, you realise that this is a patient who's bleeding internally, and you want to give her some blood.
So our little pause point in this case, team, is we're just going to consider a bit about paediatric MTP in itself, because I've never run an overt massive transfusion for any protracted period of time on a child in my emergency medicine practice, and I haven't looked after a case like this in my retrieval career. So that was just worthwhile remembering or refreshing on some of the physiology that happens in kids that are bleeding, and then looking at some of the numbers in terms of how we would balance an MTP in our smaller population. So this patient probably has a circulating blood volume of about 80 mils per kilogram. The smaller kids, down into that neonate and toddler era, up to about 90 mils per kilo, but as they get a bit older than this, they're kind of matching our physiology and our blood volume. We know kids don't give us the same physiological external signs of shock that our adult population do. In particular, frank hypotension, such as in this case, is a very, very late sign and one that should herald our concern. But prior to this, a narrowing of the pulse pressure is something that we would expect to see leading up to hypotension. Just a reminder that kids have a much higher oxygen consumption, and their cardiac output is largely fixed on their heart rate as opposed to stroke volume. So they're going to mount that tachycardia more than anything else. That's their big physiologic compensation. When we're running an MTP for kids, the volumes are similar to what you would kind of expect from fluid boluses. I think the easiest way to remember for most of our blood constituents is 10 mils per kilo is a pretty easy number to remember. And then cryoprecipitate is in a smaller bag, so you give a smaller dose. So you just give a 5 mil per kilo bolus for cryo. And I think they're your little single units that you need to remember for cases like this. More and more frequently, I think we are seeing children, not necessarily that need MTP, but we're giving tranexamic acid. And the literature's a range of 10 to 20, but I think the Sydney Children's Hospital Network recommends 15 mg per kilo as a slow IV push over 10 minutes up to 1 gram, our adult dose. And I know we don't carry calcium gluconate. We've got our chloride in our pre-hospital box, but 0.1 mils per kilo of 10% gluconate would be our dose of calcium if we're worried about citrate toxicity in these cases. I guess perhaps 0.1 per kilo of calcium chloride, but again, I'd have to look into that in a bit more detail. I hadn't thought about that on the way in. When we compare then, what we carry, so for our retrieval service here with our eskies of blood, we've got 3 units of red cells, or this is the helo mission, so we've got 2 of red cells and 2 units of plasma. That's about 500 mils of each. You take a rough unit to be 250 mils. In this child, 1 unit of blood is approximately their dose of 10 mils per kilo as a bolus. So in our yellow esky, if it's a HEMS team out there at Mudgee looking after this poor young girl, we've got 20 mils per kilo of each. A pretty reasonable volume, over half or about half of her circulating blood volume in our esky to take with us. And you compare that to the benefit that we often give our adult patients that we have bleeding. We'll bring hypovolemic patients back from the brink with our 3 or 4 units of blood in those eskies. If you take a not-so-average 80-kilo adult around Western Sydney, they're only getting about 6 mils per kilo of each. So relatively, we've got, our little esky can go a long way with these kids. The most recent Code Crimson, the PEDS population that we've had for this service down at Camden Way that went by road into Westmead Children's Hospital had exsanguinating pelvic vascular injury, but it was a dual retrieval response and both eskies of blood were used. That child, I think from memory, had about 70 mils per kilo of blood by a pre-hospital team, which no doubt kept her alive, replaced her circulating blood volume with someone who would have otherwise exsanguinated on scene. So a lot goes a long way. But with that, I think we need to be responsible with the volume of blood. Like when we're in our major trauma bay or in theatre and you've got a MAC or a RIP line running through a Belmont rapid infuser, it is so easy to go the other side and to overshoot the mark and overcorrect volume resuscitation. And I think we really do need to be careful when we've got cases like this, that just because we have 4 units of blood products, that we don't just dump it in without considering that volume and make sure that we don't create a volume overload scenario. And so we're constantly reassessing after each dose of volume that we're giving. Taking a step back now, if we're on our way to Mudgee in the back of the helicopter and you're wondering, I don't have blood with me. Perhaps it went out with the roadies earlier on. I wonder what's at Mudgee. We can use the Item Trauma app to have a look at that on the way. So using the little click buttons that you see there, and that'll give you a list of what should be in the blood bank at Mudgee Hospital, which we'll show you later in this story. But that's how you can plan ahead. It's a little can-do hospital when we look at it. Thanks, Chris.
So, as Chris said, conveniently for this 26-kilo girl, 10 mils per kilo is about a unit of blood. And so while you're in Mudgee Hospital, you give her a unit of blood. This is now her 2nd unit of red blood cells. You give it through the warmer and give her some analgesia, and you start to get a bit of a response. Her heart rate comes down to 135 beats per minute. And so while you're there, you give a 3rd unit of red cells with a little bit more response, and you're feeling slightly more comfortable. The emergency CMO has arranged a trauma CT, and the radiographer comes in and says the scanner's good to go. What do you guys want to do with this at this point? Laura? Anyone? So the CT is ready, but you've got this girl bleeding.
I think at the moment what you really want to do is find out, well, you really want to work out where is your...
So I'll grab the microphone for you.
Sorry to put you on the spot, Laura. I just looked up and saw you there.
Never make eye contact with the speaker.
It also helps when they know your name. So I think at this point you really want to work out where you're going, if this can be fixed locally or you need to be moving somewhere where definitive care can actually happen. And as much as having a bit more information will help, particularly the surgeons know where to control the bleeding from, you know that they're bleeding abdominally. And you want to see if they're either going to be stable and the bleeding is sort of stopped at this point and that you might be able to go to the centre and get more information, or if you just need to go somewhere where you can get definitive care and someone to actually fix the bleeding, because a CT scanner is not going to do that.
Yeah, perfect summary of that sort of situation. That, you know, you probably in this case need to go somewhere that's going to definitively fix the bleeding. And although you might have a surgeon on at Mudgee who's willing to open up a paediatric abdomen, that might not necessarily be the right thing to do. And so in this scenario, I think you want to move to one of the children's trauma hospitals, likely Westmead, and a CT is just going to slow you down. What about an RSI? There's a GP anaesthetist. They've been called in. I sort of think probably a similar story. If you don't need to intubate the child, then that's also going to slow you down. Having said that, you need to have a contingency plan if that airway is an issue, and that you need to have a discussion with your flight nurse or paramedic about what you're going to do en route if you need to manage the airway.
I think just a little kind of to elaborate on some of those points, the CT scan or perhaps even the consideration of a life-saving laparotomy on a kid like this in a non-paediatric trauma centre is a consideration and should probably be planned with the retrieval on the way out. When we get there, what are our thresholds for wanting to intervene locally? Not that we're going to do it, but what is the skill set there? And this is something that's going to test all aspects of the resuscitation. It's going to probably stress a general surgeon. Let's make it a bit further out. You go out to Orange or Dubbo, where there's probably more upskilled, as a stereotype, more upskilled general surgeons. But then you're going to look at the anaesthetist as well and wonder, is it a GP anaesthetist, consultant anaesthetist, and what's their familiarity with paediatric MTP and resuscitation as well? And I think that all needs to be considered with what the local resources have. And then the discussion about to tube or not to tube, I think in this instance you've got someone who is at the moment maintaining their airway, but that cerebral perfusion becomes one of your strongest markers, I think, of your ongoing resuscitation. And if you don't need to intervene, having her alert and seeing if she's getting confused and picking at things, that might be a marker that your next dose of volume is due. So just 2 points that we'd come up with before.
Yeah. And so, yeah, to summarise that point, you know that this is a time-critical illness and the patient is likely to become more unstable without intervention. And so you've got to be really careful of the time and your forward momentum there. So now it's time to go. You package the patient with warm blankets. During this time, you've given 2 units of FFP. So that's 5 units in total that she's had now. You've given the TXA at the 15 milligrams per kilogram dose. And you've put in a call to Children's Hospital at Westmead. She's got better obs now. So her systolic blood pressure's come up. Her heart rate's 130. And so you're feeling ever so slightly more comfortable. Then the next thing, if it'll come up, there we go. What blood products do you want to take with you? And you may have used all the blood in our rescue, or it might be that you've used blood from the hospital. But between the blood at the hospital or blood from the esky, you've got to decide to take some blood products with you. And as Chris kind of mentioned before, there's the item app here, and this is the next page of that list. And when you go to Mudgee Hospital, they look pretty flush with blood. They've got 12 units of red cells, 6 FFP and 6 cryo. which is not too bad. So you say to the blood bank there, can I take all of it? And they laugh at you. They laugh at you. So at that time, it's a big weekend in Mudgee. They've got a lady with a PPH in theatres at the moment. So they just tell you that you can take 1 unit of red cells and 1 unit of FFP. So you get out to the helicopter.
The transfer part of that, which is around that alerting Children's Hospital Westmead component of it. Can I just be a really big, strong advocate for when you make that phone call, make it through ACC so that we can actually hear what's going on in Mudgee at that point in time, because there's a bunch of phone calls that may need to happen.
Yeah, okay.
That if you've had that conversation through ACC, somebody's listening in, hearing what you're saying, then you can keep that forward momentum going. So they're going to know whether or not you've got how much blood you've got from Mudgee and be able to suggest things to you like stopping along the way if you need to. If Mudgee say you can only take 1 unit, you might be able to drop in at Lithgow. And ACC really can help that. They can also do those follow-up conversations for you. You phone Children's Hospital, chat to them through their patch network, and they will make sure that the closed loop can continue while you keep forward moving. So that surgeon can phone back through to the control centre, all those things, rather than phoning back to the paramedic phone or otherwise. So I just really want to advocate that.
Really good point of sort of central communication there.
And as any important communication on a recorded line is important too. The other couple of things, we're warming the patient. We've got a active warming blanket on, hopefully, and you've mentioned calcium there. Other thing ACC have is access to the actual live blood bank stock. So the ITAMAP reports their standard stocking, but that might not reflect exactly what they have on the day. And then finally, fibrinogen concentrate is now available in Western New South Wales blood banks, and you might get some of that. So that's exciting as an option instead of cryoprecipitate.
To use ACC to get a paediatric haematologist on the phone to figure out the dose.
Just absolutely, if you need that because you don't have the information at your hand, ACC will help with all of those things.
Amazing.
But there's lots of phone calls that go on in the background, and I think unless you spend a bit of time in ACC lately, you won't realise how many of those phone calls are getting made behind the scenes. And if we have the information, we can suggest things and help offload your bandwidth, because I imagine it's going to be rather exceeded in this case. And we're a team. That's really what it comes down to.
Yep. Yeah, that's a good point. And we're going to actually get on to some of the content of when you're talking to the kids' hospital and stuff in a moment as well. But just to sort of finish up with the case here, you're transferring the patient, you get to a helicopter, and they've got a blood pressure, a systolic blood pressure around 80, and you're aware of the concept of permissive hypotension, where you tolerate a lower blood pressure to stop disruption of a clot and to conserve blood products. So you're quite happy with the blood pressure about 80 because she's mentating well, and the capillary refill is about 2 to 3 seconds. She does transiently drop, but she responds to giving some of those blood products that you've taken with her. And now you're about halfway. You're looking out the window because you've been working really, really hard so far. So you just take a moment to check out Wentworth Falls. It's looking pretty good at the moment with all the rain. But then your paramedic or flight nurse draws you back because you've run out of blood, and she's looking more unwell now. Her blood pressure is 70 on 50 and her heart rate's 145. So at this point, you want to communicate with the hospital. And so just a little thought about what you want to say when you call or speak to the hospital on the radio to pass a code 3.
Would anyone like to take that as a sample call? You've all heard the case. Just to throw any confident person out there. I really want to say Rob because he's on his phone.
Rob's taking a call, is he, or is he making a call?
No, I'm sure it's very busy DRC.
He's texting the admitting officer.
Sorry, Rob, you've been selected.
Sorry, Rob.
So I'm communicating through to the kids' hospital. Yeah. Is that right?
Yes, please.
What do I want to say? So we've already given them a notification, or this is the initial notification?
This is an update.
An update. Basically, I want to, identify myself and where we're coming from, give them some context, and at this point, we haven't actually called this a code crimson. Do we want to do this now? Look, I think, and probably where this is heading is calling this and activating the system is only going to really help in this setting, and particularly with the kids, to sort of the kids' hospital, to heighten that awareness. This is an unstable child. They've had ongoing blood transfusion. They're still they're not in a stable state currently. We need more blood. We need surgical intervention. We know they've got a positive fast. So I think at this point, I'm trying to simplify the message to being become further unstable, activating a code crimson.
Thanks, Rob. Sorry for putting you on the spot. I think that's the topic that we want to bring up in our last couple of minutes, is that the trauma code crimson pathway applies to pediatrics as well. And out of the 100, as Chris pointed out, over the 100 or more activations that just our service in Southern has launched on code crimsons since 2017, 5% are kids. And so there's, it's a rare event. Maybe one a week on average, one every 2 weeks. 5% of that, it's a rare event at our children's hospitals, and we just want to bring this to everyone's attention. So the code crimson is for our persistently hemodynamically unstable patient who've had standard trauma care. They've been intubated if they've need to, they've had blood resuscitation, antifibrinolytics, they've had obstructive shock ruled out or managed with pleural decompression, and they're still unstable despite volume resuscitation. If you were getting that call at the Pediatric Trauma Centre, how would you respond? Really, this is not a ED bypass direct to operating theatre response, particularly in children, where we know that a lot of high-grade solid organ injuries are managed more conservatively or with more selective angioembolization than our adult patients. I think what this should be doing is bringing everyone to a common location, being pre-briefed by a team leader and having senior decision-making from the moment that patient arrives, or even before that patient arrives to that facility, whilst having everything ready to go for the next step. Having an operating theatre on standby, warmed, with things primed, having the blood warmer primed in the resus bay, having blood bank alerted. There might be a request for this patient who is now peri-arrest to provide blood products onto the helipad for their immediate arrival.
Which I need to tell you won't happen.
Won't happen.
So please, if you want that, please ask for it. But currently the situation at Westmead Children's is that they are drafting a protocol about helipad access. And while there is no protocol, their unofficial line is we can't bring blood to the helipad. But that doesn't stop us asking for it, because the more we ask for it, the more they recognise there's a need for it. And I am at least in conversation with them about making that happen. So please do ask.
Thanks, Nat. And so we're bringing the party to the patient for their arrival to make a sensible consultant-led decision within their first 10 minutes of arriving. We're providing them with ongoing massive transfusion in a protocolized manner. We're getting the consultant surgeon or IR or orthopedic surgeon or thoracic surgeon, whatever's needed, is there at the time, providing input with the ongoing resuscitation team in the ED for the next step. But most importantly, that pre-alert that Rob's mentioned primes a system so that all that kind of flash party suddenly has some structure by the time that the patient's arrived. Everyone's got their role, everything's warmed up, there's a brief ahead of time. all they need to do is see the patient and in that first couple of minutes reassess, hear the story and make the next step. And so if you are working at a paediatric trauma centre, and this is something that isn't yet drilled or practiced, perhaps it should be. At various trauma centres for our adults, we use a readiness checklist because it's a rare event. And whoever takes that call will start to make the calls and go through this A4 page to make sure everyone in the know does know about these impending patient arrivals. And I think the patients, from the literature that we're soon to have published, despite these people having significantly higher injury severity scores and higher hospital lengths of stay and longer days on the ventilator, sicker physiology on arrival, there's actually an improvement in their mortality compared to those who don't. So I think the system is beneficial, and we do need to start preparing for it, even for our smaller patients. In this case, they settle down with the next 2 boluses of blood volume in the emergency department. There's a decision made to take that trauma team to CT, where a high-grade splenic injury was identified, and then the patient rolled on with anaesthetic support to IR and had selective angioembolization and an improvement in physiology. She's back riding horses somewhere out in Mudgee. That's the end of the story. That's as far as we've created it. Hello, Ed.
I've got a question. I'm Amber. Hi.
I was going to give you a microphone, sorry. We've got lots of people online and they struggle with you.
Hi, it's Amber from Nets. Who do you call at the children's? Are you going via switch to the trauma person who's on call for trauma, or are you going via ED?
So traditionally, most of these cases will come from a pre-hospital tasking. So our critical care paramedics will be making that via the radio, via a normal bat phone. So whoever picks up that bat phone at Westmead or Sydney Kids will need to know what that phrase means, and then what do I do with that information.
But subsequent calls might go through to the admitting officer in emergency, who's the usual person to contact, as we usually have a direct line to them.
Are there any other thoughts?
Both of those phone calls happen. Reckon that if you phone and talk to the ED admitting officer, that you always still phone the bat phone, because the ED admitting officer can sometimes be distracted and not tell everybody working in the resus bay.
I think
and also the vehicle it's travelling in. So having had a lot of hypotensive patients in a 139 has quite a long translation as it's coming into fly, and it vibrates quite markedly. So when you have a hypotensive patient that's bleeding, you've got to be prepared for that patient to actually crash on landing. Not physically crash.
Ask the pilot to land.
Nothing wrong with the pilots are fantastic.
We don't have any pilots in the room today, unfortunately. But yes, you can ask them to land quietly. Yeah. Rob?
Just a little comment, just about who to call. I think it's important not to complicate it too much, but this, because they have come from a hospital, it will get or can get a bit complicated activating a code crimson when we do traditionally do it from the pre-hospital setting. So I think that's just really where having ACC in the loop is so important. Because more than likely some surgeons at Westmead have been put in the loop from Westmead, from Mudgee initially, and all sorts of people are going to be starting to get whispers of it. I know even just in the adult setting when we've had inter-hospital code crimsons, it's just got can get messy. So, I think the key in my mind is just, getting ACC as that central communication point is important.
In the interest of time, we're going to move things.
I think we might move on.
Tight schedule. So
2 talks in when we're running late.
Okay, well, thank you very, very much. It was great. The 2 Chris's.